Log on, tune in, find out. Another good idea from Cambridge.
First an economist under 40 last year went to Esther Duflo, a French woman at MIT, who's probably done 100 cluster randomized trials of economics interventions for less developed countries and so forth. So, and they say openly, though, we're borrowing from the health sciences. And so, there are a lot of interesting developments going on all over the place. They have all sorts of good ideas. Well, I didn't put the book address. Well, clusterrandomizedtrials.com, and I think you can spell it either with the Z or with the S. Either way, it'll get you there. Yeah, had to make sure. I'll just go right on now. So this is just, will do it automatically, yeah. So I'll talk a bit about this study in Brazil, a tuberculosis study, and spend about the first half. I've got way too many slides here, about 45. Let's see, is this the pointer or is that the pointer? On the design of the study, looking at power and sample size issues and about randomization. Are you Rosemary Bailey?
Yeah.
Oh, good, because I'm sure the whole idea here is from you. Although yeah, I know, but the whole idea here is from you, but you're going to hate it. But then I'll spend more time, hopefully, on some of the problems we've had, which we just mentioned, of what you have in these cohort trials, essentially, in a stepped-wedge design, and we actually have some results now. So this is half the reason we did the study in Brazil. It's just a nice place to be. Okay. The other half is our collaborators who are in the Ministry of Health there and are in charge of all of HIV and TB in Rio de Janeiro. So it's just been an incredible team to work with. And this work is mainly funded by the Gates Foundation as part of a consortium of very large cluster randomized community intervention trials in Southern Africa and Brazil. I'm not going to say anything about the software. But now, the basic idea is that this is a health services strengthening intervention. Basically, we know we've had this drug around, INH, isoniazid, for decades, and we know that it can prevent tuberculosis in people if they take it on a regular basis. Back in the 60s, people were putting in the beer of South African miners to prevent tuberculosis. The problem is that it's really not getting to people. There's a lot of worries about resistance and so forth if you use it on a mass scale. And the idea was to train clinic personnel to take all the HIV positive patients. These are special clinics where people can go and get free antiretroviral treatments, give them a tuberculin Stein test, and if they're positive, then that is, they're infected and at a much higher risk of getting TB, you put them on isoniazid prophylaxis and try and prevent TB. So the intervention is health services. They're intervening at the clinic level and training the personnel, and there is a resource constraint because everyone was so dispersed, train everyone at once, so they said, well, we're going to train 2 clinics worth at a time and step that in over the first couple of years. And then once you're in the intervention, the clinic is in the intervention, every half year you're getting repeated trainings as well in case some of the clinic personnel change and so forth. So there were 29 clinics. So the sample size that we're randomizing is 29 clinics. Most of the clients are on heart, but some aren't quite there yet. And we're stepping in 2 at a time. And so we'll go over a bit about the loss of efficiency from the stepped-wedge design that I referred to already, and then there's within clinic correlation we have to handle, variable size of clinics. Once you put all these factors in, your power is shrinking and your study gets bigger, but we were limited by the number of clinics. We could only really operate in about half of the clinics for other logistic reasons that were in Rio. And then we'll talk about the bit of using a highly constrained randomization. So here's our stepped wedge, and now we have 2 clinics coming in every 2 months. It takes about 2 months to to really finish the training. So we have 2 clinics, 2 clinics, 2 clinics, and we get up to the point where all 29 clinics are in. We are also granted a long intervention and follow-up period. So at this point, all the clinics are in the intervention phase, and we're following them up through time. And I'll get to that because we're going to actually have 2 different things to think about. There's the clinics being in intervention phase, and then there's individuals being in intervention phase, which is a different matter because these people aren't just showing up every day at the clinics. And basically, we end up using, thinking of this as a Poisson process, people getting a TB and/or death, and what we're looking at is that every single day of the trial, who's becoming a case and who isn't, conditioning on that day, and that way perfectly handling secular trends. So it just ends up being one big Cox model in the end. We handle a correlation with the standard gamma frailty model. We actually programmed the same model in both Stata and R. Stata has they both have built-in routines, and by golly, we get the same results. It's a good check. It's used a lot in industry. People have different programmers using different software, see if they can get the same results. Just it's an additional robustness no one ever talks about. It's the kind of luxury you have when Gates is funding your study. So the first thing is accounting for the wedging. We'd had Richard had worked out a formula that shows that for Poisson responses, the limit with the number of steps is for the design effect due to stepped wedging is 1.5. So if you have an infinite number of steps, you need 1.5 more clusters than if you just have a parallel design. But I figured that just for the heck of it, we'd check that and use log rank weights, which would approximate the Cox model. And I put these the expected numbers of events and so forth into where's my Excel spreadsheet just to see, in fact, what ratios I get. And the smallest number on the page is the most important one, of course. It ends up, we get a design effect of about 1.4 with 14 steps, and if there were more steps, that would be going up towards 1.5. So this is an inflation factor multiplied by the number of clusters. So that's the 1.5 I mentioned before. That's why, on average, it takes people longer to get into the intervention. Then we had to worry about the correlation within clinic, and this is really a chart review study. And so we said, well, we better see what's in the charts. People have been looking at them just to make sure that we can get the data, but then we did a non-random sample of 10 clinics. We randomly sampled 24 patients each just to make sure we could get the TB incidence data and to see what kind of variability there was. And we got a pretty small coefficient of variation. It's so small I just didn't believe it. So in our sample size calculations, you generally use larger numbers than that. But anyway, because of the intra-clinic variabilities, clinics are in different geographic areas. They have different clientele, different people working in them. So there's definitely going to be some correlation. In the final adjustment, we use the harmonic mean of the expected person years in the clinics to give a final adjustment for how many person years were needed within each cluster. So that's another inflation factor, but on effectively a deflation factor on the effective person years in each cluster, which went from 600 to 350, which is quite a drastic reduction too. But again, the diminishing returns is with the number of people in the cluster, so it wasn't that bad. Anyway, what we did was then we just took different scenarios of the rates and control and intervention rates and solved, essentially we took the control rates and with the other parameters solved for the intervention rate that was detectable to see with a 80% power 5% alpha, what we could find. And generally we're finding, well, about 40% effectiveness. And that's effectiveness over the whole clinic population. You know, if you actually take one individual and you prophylax them and they take their drugs, it's going to be 95% effective. But you know, there's various things that come into it. You know, whether they're testing on time and so forth. And so we thought 40%. Well, if we did find that, that would be important fact to know in this public health intervention. That really doesn't cost that much to really go and make sure people are doing what they should be doing anyway. Okay, so now the randomization business. It was interesting to see that I think none of the studies you were looking at were blinded. You had another term though, what was it? It was not blinded, but the allocation was concealed or something. In this case, what we did was, you know, it wasn't blinded, but we only let the Brazil team know 4 months in advance which, you know, what the series of intervention was going to be. See, we didn't want to tell them 2.5 years ahead of time that, you know, this clinic will be the last one to be intervened on. So if that information got around too much, there might be behavioral changes, like someone was saying. They might say, oh, you know, they're doing this, we should try to do that too to be up to speed and so forth. So we revealed that, we unconcealed it in a time-varying manner. Now, because there's only 29 randomization units and there's a lot of baseline covariates we had, you know, whether there was a directly observed therapy program operating already, there's geography, and then characteristics of the patient population, the number of patients and their CD4 on entry, their educational levels. And we wanted to make sure that we had some good balance here. There's so many variables you can't really stratify. And, you know, for 1 or 2 variables, you might be able to stratify on a stepped-wedge design, but not more than that. So basically, we're using this highly constrained randomization approach, whereby you reduce the total number of possible orderings down to the ones which are acceptable to you, and then randomly choose one. Well, we'll go into that. First of all, the constraints, we just used a very ad hoc type of constraint for every covariate, which basically takes the weighted number of months of that covariate value by the number of months it's in intervention status, and compare that with the weighted number of months it's in control status. And basically, it's just like a parallel design. You want, in a parallel design, you want, say, 20% of the patients to be below 200 CD4 on entry and in the control group, and 20% below 200 on the intervention group. And here it's weighted by the number of months, but it's the same idea. You want those 2 groups to end up close together on these covariates. So we just use a very, very simple constraint here with the CJs are the percentage within each side, you know, control and intervention. We have the covariates, these APs are geographic areas. And so these are the proportionality constraints. We want them to be within 10 percentage points of each other. So this is what we wanted. We ended up something pretty close to that. And again, I'll just show you the geography. These are the different geographic units here. What we actually couldn't list all 10 to the 26 ones. So what we do is we randomly generate sequences until we got 1,000 that were acceptable by these constraints. Okay, then we carried out the, whoops, I don't know how to get back unless I go to this. So then we carried out the final one in a quasi-public randomization ceremony. Now, we had, in our Zambia study, it was mainly the London School people, it was a public randomization ceremony. You know, they got everyone together, and it was a big party. You know, they had representatives and workers from all the different areas that were involved, and basically had these headmen choose soccer balls that were numbered out of bins. And so it was very clear to everyone, a very transparent process, that someone wasn't trying to, delay you from getting the intervention. This is just how it worked out. So that can backfire sometimes too, but it worked out pretty well for them. I think the first time was with ping pong balls. Well, this is quasi-public because it was really just the Hopkins and Ministry of Health researchers getting together and doing it. And now this is the advantage of being in academia. Many of the people at the conference are from industry. You could never get this kind of thing past the FDA, where you use the lottery to select your randomization. It's not very reproducible, but I figure it's actually more random than a pseudo-random number generator, and so what the heck. It also had the advantage that if someone didn't like coming in at the end, the Brazilians could say, it's not our fault, it was a federal lottery. There's some advantages to this stuff. Anyway, you can't have that much fun in the industry. All right, now the problem is that you got to worry about validity, because here we've done this incredible constraint on the randomization, and it's not clear what it's done, what correlations it's induced in terms of units entering together. And it was, I think Rosemary is the only one here who's ever paid any attention to R.A. Fisher on this subject, because everyone talks about unbiased designs. Everyone have the same chance to get a treatment or not. But if you look in clinical trials books, you can't find anything on the validity of the designs. And it's really strange. I've asked, I won't name any names, but I've asked the writers of those books, and they've even heard of it. Okay? And so basically the idea is to have independence of action of the randomization. Because if you don't, for example, if you have a parallel design, every possible randomization under your scheme, if you have two units that always end up in the same treatment arm, well, effectively they're the same randomization unit then. You've lost the degree of freedom. Okay? And that can happen if you put on these incredible constraints. You could end up essentially having them all end up together, and so what's the difference between that and just treating them as the same randomization unit to start with? So really you have lost that degree of freedom. And so that's something we have to check to make sure that our system of constraints hasn't overly constrained it. Now, because of these constraints are so complicated, there's no way you'd figure it out. Just to do the very simplest things, excuse me if I say it's simple when it appears in Biometrica, but just very simple designs takes all these incredible, algebras to figure out whether you're doing the right thing or not. So here, what we have to do is just do an ad hoc check to make sure that we haven't effectively made units co-occur too often. Okay? Now in this case, what we're worried about is having each pair of units having the same chance of entering the intervention status at the same time. If they're always entering at the same time, then essentially it's one randomization unit. You don't want that. Okay. And I've done a bunch of simulations for parallel designs. Basically, you've got to have huge underlying correlation, not the induced correlation from the randomization. You have to have huge underlying correlation, say geographic correlation between units, and maybe a 10 to 1 ratio of appearing together versus not before you really start to impact your type 1 error. But still, you've got to check this. And so, once again, the trade-off is you want to constrain enough so that you get the balance, but you don't want to constrain so much that independence of the randomization is lost. I have no idea even if minimization is a valid technique. Well, I'll let you talk about that later on. So anyway, we had our 1,000 that were acceptable. I did another 5,000 because I needed more to be able to do this check. This takes a while because it took 89 million samples to get them. But with those 5,000, then I could look to see how often things were showing up, and actually it led to me loosening up one of the constraints, and then we did it again, and then we were pretty happy. And anyway, well, what it means, if you look at how many times the pairs are together, if you have a completely valid design, you're going to expect 172 co-occurrences in each cell of this matrix, and this matrix goes on over here. But yeah, I just wanted to give the idea. Here I have 29 clinics here, and the same 29 across here. And so, for example, here's clinic number 3 and 7 appear together 132 out of the expected 170 times, and some of them are lower, some are higher, and it gets up to a 2 or 3-fold difference sometimes, but that's not bad. Sometimes you put on what you think is an innocuous constraint, and you find out that there's a 10 or 20-fold time that things almost never can occur together, especially if you have covariates that vary a lot. So that to get balance, you might have a community that's very poor, always getting in the same treatment arm as a community that's very rich. So that on average, that balances with the others, because if you put poor in one and the rich in the other, then this one would always be poor. And so if you have a lot of variability in those covariates you're matching on, the more variability there is, the harder it's going to get to get to validity. And so the idea is that it's an iterative process, and if you constrain too much, you got to loosen up and do it again. And so anyway, so this is, I call it a, yeah.
So these, am I understanding this right? These zeros below
yeah, that's just a symmetric. You would get too busy.
They're not zeros.
Yeah.
You relate.
Yeah,
Okay.
yeah. Well, then you're looking all over the place, and you're looking twice as much as you have to. So it's for lazy audiences. Okay. No, yeah, no. It's just how many each pair is occurring, and there's no ordering to the occurring. They're occurring at the same time, those pairs. And we ended up the actual differences on these variables. The balance came out pretty well on the weighted months of intervention and control times the covariate values. Actually better, usually you'll have better luck than the worst luck that you plan for.
How is that measured?
Yeah,
Actual column?
Yeah, so this is when I actually got my one final randomization that we chose then. And then for that sequence and the covariates, we added up and see what is the weighted sum of a covariate on one in the control arm versus the treatment arm, and then that's doing that for each of the clinics, and look at the average, just the difference. Yeah, weighted difference and the averages between those two. And better than the constraints, of course, and on average you'll be better than that. Okay, I don't know, how many of you folks have seen that? How many people have seen that quote before? Oh man, good. Good was great. So, anyway, we had to compensate for a lot of factors in sample size. We're about to go into the analysis part. Correlation, time-varying ratios, trial arm sizes. I mean, that's why we're losing efficiency, right? Because in a stepped wedge, if you're comparing at each point in time, on average, you have imbalance. It's not a one-to-one, which is usually the most efficient design. Most of the time, you're unbalanced. Now we use the rather simple, although greatly restraining set of constraints. Other weighting systems might be of interest. I'm sure you could have better ones than the one we've used. But, we're happy with it. It seems to work. And the stepped wedge design we did it both because it was politically suitable, that's what I meant by suitable, and logistically feasible. We really couldn't train everyone at once. So now we'll move on to the results here. And these were presented last month at the International AIDS Conference in Rome, so they're pretty fresh. But we're still reconsidering one or two of the parameters in them, and so don't quote any particular numbers. It's okay, I guess, if we film me, but I'm not going to upload the actual final slide. Although anyone seeing the show will be able to see it, I guess. Anyway, in the main analysis, we're looking at all the events that happened during this 4-year period. And we have data on patients from 2 years starting, that they have patients who are in the clinics, and we review their charts every once in a while, but we could have done this study just looking at their charts once in 2010. That is, we could have just done one data collection, but we wanted to see how things were going, and it would have been too much data to collect all at once at the end anyway. So again, it's a retrospective chart review of a prospective cohort. Now, the basic idea is that we're regarding patients as staying in the denominator until one of two outcomes, TB or death, and we ended up with two outcomes. The main one was tuberculosis incidence, and the other one is tuberculosis-free survival, the complement of which is the first of TB or death. Okay, so it's a combined outcome, TB or death. And that's because a lot of these patients aren't showing up, they're dropping out. And what we've seen in other studies is that basically they're going home to die. TB is the #1 killer for people with HIV, and once they get really sick, usually, often they might change care, they might go somewhere else, and we're able to capture the deaths in the state of Rio de Janeiro mortality system. So that let us catch, but we don't have enough confidence in the death diagnosis to really use that. So that's a combined outcome. All right, we have a restriction here. The results are among those who are eligible for the intervention, which is the skin test followed by the INH under the Brazilian system. And as we'll see, we did also a stayers analysis, which was looking at those who we knew were coming back on a regular basis. Now, the main analysis is really based on when the patients had the opportunity for the intervention. That is, a clinic is going into intervention phase, but then we're not saying the patient is the intervention phase until they show up for the first time in their clinic after that clinic has gone into intervention. That is, after they receive the training to deal with the patients. Patients are supposed to be showing up every 4 months. Let's see, I'm not sure that picture is later on. I should have put it earlier. They should be showing up every 4 months, but sometimes they're going half a year before they're showing up. So while we have a Cox model with clinic level random effects where it's tracking each patient individually. And so we've got this binary covariate that's starting out at 0, they're in intervention phase, and then the clinic changes, and then the first time the patient shows up in the clinic after it's in intervention, then their covariate goes to 1. And I haven't proven this, but simulations I've done showing the exact same result as if you use a time-varying covariate that is at the level of that is recalculated every time there's an event to give you the proportion of individuals in a clinic who have shown up during intervention phase. And that's an idea that is in the Hussey and Hughes article referred to earlier to deal with these lagged intervention effects. Okay, because, and often you see that in these stepped-wedge designs, and an intervention is put in place, but really, it doesn't start from day one, and it might even take a year for some interventions to be fully implemented. And that can be because people aren't, all the nurses aren't getting up to speed or something, and here, it's because the patients haven't come in to be intervened on yet. So there's this lag effect, and so we handle that with this time-varying covariate that tracks when they're getting intervened on. Now, in any real-life data set, we have problems. The first is that we don't know when they make clinic visits. However, we do know when they're making meaningful clinic contact, that is when something's happening enough so that it shows up in the record. And CD4 is the most important one and the most regular one because it's supposed to be tracking the person's CD4 to see if they either should be going on heart or if they are on heart, if they've, it's another measure of whether it's working and whether they're being adherent to it. And the other thing is that we're keeping out prevalent TB. Okay, so because some people won't even be in a clinic, they might not even know they're HIV infected, and all of a sudden they start coughing, so they show up at a clinic, and that's when they find out they're HIV infected. They have TB at that point in time. well, there's no way an intervention is going to do anything for them. And so we're keeping the prevalent cases out. Same thing for prevalent deaths. I know there's no such thing as a prevalent death, but it's the same deal. The ones that show up at the clinic and then within 60 days they've died, we don't count those. And we may be putting this to 90. We've been doing some more looks at this. Similar thing has been done by Richard Hayes, Catherine Fielding, in another TB study. So let's see. Okay, I got this. I keep reiterating this. The patients are different from the clinics. So what we want to do, I should have labeled this as what we want to do. So the Cox model is looking at slices in time like this and comparing intervention to control. And then we add up all the slices in a weighted fashion. Now, because it's a Cox model, we're still making vertical comparisons in this follow-up, but the vertical comparison is really diagonal in the sense that there's individuals who have not yet entered the intervention phase. So that there's essentially, some individuals are like they're back in the control phase and they're being controlled compared to those who are in intervention phase at this point of time. So it makes it sort of diagonal. I didn't show a diagonal on the picture here. But so essentially, the main analysis, the clinics are handled as intent to treat, but then the individual patients aren't treated until they show up in one. Use a calendar timeline. You have a dynamic cohort because there's ones who are already registered in the clinics before September 2005. There's also about a third of them during the time have come in during the study and they've made their first contact. And so we count them from the time that they show up. If they show up in the control phase and they're in control, they show up for the first time in an intervention phase, and then that individual's in intervention phase and was never in control phase. Okay, so individuals may only be in one phase of this. Okay, and we had one hell of a time. You know, it's an extreme version of Pareto's law. It took us 95% of the time dealing with the last 5% who transferred between clinics and figuring out what to do with them and how to, it's just, it drives you crazy. 95% of the time is spent on the last 5% of the data instead of 80-20, which Pareto had. So again, here we have the study timeline, 2005 and 2009 for the main analysis. For an individual clinic, it may have had its first clinic training at this point in time, the green, so that's when a particular clinic gets its intervention. An individual, though, is coming in repeatedly. That's what these blue arrows are for. And they're in control phase until, that's yellow, they're in control until the first time that they come in and their clinic is in intervention phase. So the clinic was in intervention phase here. They're still in control until they show up in the intervention phase of the clinic. So at that point, that person is going from 0 to 1. Should have shown that one before. Now, there's a lot of loss to follow-up, as I said. So what we did was put in this thing called a Stayer's analysis. And, or according to protocol-like analysis. We had no protocol for it, of course. It's just that patients are supposed to be coming in every few months. So what we did was, basically, we said they had to have a really meaningful visit, which is a CD4 cell count, at least annually, to stay in the denominator set, the patients at risk. So we follow people from the moment they enroll until the point where they've gone a year, and this took some programming, of course, until they've gone a year without a CD4 cell determination in their medical history. At that point, we censor them for good. If they show up 2 years later, we don't bring them back in. We say these are not stayers. They're not people who are really in full and constant contact with the healthcare system. They're supposed to be showing up 3 or 4 times a year. So this didn't seem like that much of a constraint, although it did change things quite a bit, as you'll see. But again, this is a secondary analysis. But but a parameter of interest. What happens with this protocol when you are dealing with a relatively adherent patient population? Just answers a different question. Okay, so here's all the data. This is calendar time here. The X's are the steps of the clinics. So those are the clinics entries. So that's, again, we see a stepped wedge here. And blue are the TB cases that are attributed to the control period. Red are the TB cases attributed to the intervention period. So before any clinic is phased in, all the TB events are blue. They're all in the control. However, there are individuals who are in the control phase here. They're coming along. Their clinic was intervened in, but they haven't shown up until maybe they showed up here, and then 4 months later, they became a TB case. I'm sorry, I got to a red one. I want to go one of these blue ones here. And a few months later, they got to a TB case. So even though their clinic is in intervention phase, their case is counted as control. And so when we're looking at this slice of time here in the Cox model, that person became an event and their covariate is 0 compared to people who've come in and they're during intervention phase, their covariate is 1. And you see, we still have blues occurring. They get rarer and rarer all the way up to the end here. And so we're actually still squeezing information out of this lagged implementation, the implementation being when the person actually shows up. So otherwise, if you just did it based on clinics entry, the study would be over here. There'd be no more information added. So those are all the TB cases, 475 of them.
Can I just ask about that slide up?
Yeah.
So what does it take for one of those blues to be red instead? That they've had an earlier clinic visit?
Yeah, so to
or
be
how much
red,
earlier?
yeah, so this red person, they must have shown up sometime between the clinic intervention and they became a TB case. And maybe they showed up here and...
but does that have to be at least a respectable gap, or could they have shown up 2 days earlier and then
well, if
2
they...
days later they showed up and had TB?
Yeah, if they've been in the study already, if they've been showing up at the clinic already, they could show up the day later with TB and they would be counted against the intervention. If they've never, ever been in the system and they show up 2 days after the clinic was intervened, then don't even enter the denominator at all. Those are the prevalent TB cases. It took us forever to figure this distinction out between those who've been in the system and then those who've come in later. So ones who've been there, essentially, you want to compare them to, what's going on once you've got the clinic going. And once the clinic's going, if you've got a patient there, well, it's tough luck if they don't show up. But
You can't do anything else. Once the intervention starts in the clinic, it's not going to affect patients.
Yeah, it's not. There's no campaign. There's no campaign saying go out and get your brother and bring them in or anything like that. So there's no informational or media campaign going that happens there to bring them in, which would be a problem then. Then you would have contamination. So that's sort of a before and after analysis if you look this way. Here's another before-after analysis. This looks at control rates versus intervention rates, and you can't see them all, there's 29 points there, okay? And the size means it gives you more size, the more events, TB events there were. There was one outlier here that had very little effect on the analysis because there were only a few TB events in which the control phase for this clinic had very high TB incidence and then it was very low afterwards. And so basically you want these things to be done in this half, but a lot of them weren't. So, but that's just a very simple before-after comparison. Another comparison, a pure vertical sort of classic stepped wedge thing, which stops when everyone is intervened. It just looks at the 2 months of interventions in each time. If we look at all those two months times and we compare intervention to control, almost all the time, it actually looks like the intervention is worse. You have higher rates. And basically, I think that's because more people are being detected in those first 2 months. Somehow, the training is also getting people more aware of looking for TB or something. So if you did that, just that straight up and down 2-month analyses and look at all those, I didn't even bother to calculate a number. It was too scary. Now here's another check I did, because you worry about secular trends, which was that I took those differences from this graph, took those differences, and now those are the differences after minus before, and I plot those differences by order of entry. Because you worry maybe there's something funny going on, that the first clinics, the effect is having a different value than later on. If anything, it looks pretty even here. We have that one outlying clinic again, and possibly more variability at the start. And maybe it's more variability of intervention for the first few clinics that enter. They hadn't got it down yet as to how to teach the program and so forth. But in general, it's just sort of a diagnostic we thought of to look for problems with secular trend. Because again, it's this one-way crossover. Okay. And another thing we did was to take the last 5 clinics to enter the intervention phase, that is, the 5 clinics that had the most control time, and use those 5 clinics, remember they were randomly decided, although 5 is a small number, and then just smooth their rates over the whole time to look at secular trend. It's just an easy way to look at secular trend without having to sort of add things up from all different clinics. It's the same clinics over time, so it gives you more sure idea this is what the secular trend looked like. And this is what the hazard rate looked like, going up and down over the period of those 2.5 years. Now, one of our epidemiologists noted, by golly, that's just the shape of our famed Sugarloaf Mountain. Even this little bump here showed up here. And we were in the room at the time. She just pointed out, and there it was. And so we superimposed it. And it was pretty close, although we had a higher peak here. But it matched pretty well otherwise. It's one of those cosmic events. And here it is again, a slightly different scale and with some bands. And so it looked like there was something going on there in terms of a rise and fall.
E to the minus fifth? Is that?
Yeah, that would be on the.
Very, very, very tiny.
Yeah, that would be
That's
like a
something-
rate
those are
per
significant
day.
differences?
That would be like a rate per day type thing.
Oh,
Yeah, because we're doing it for each day.
The population of the area was into the clinic served. I mean, how did you get
The denominators are just the people that are in the clinics. So it's not population based. It's clinic based, which is a very different thing. And in fact, because the stigma of HIV, there's many people from the other side of Rio will come to one particular clinic all the way across town, so people won't see they're going to the HIV clinic. And so we couldn't really do any population-based thing or look for indirect effects, herd immunity, anything like that, because it's really just clinic populations.
And what about across the city when they know the intervention's happening?
Who knows? We probably should have done a random sample of people after the study and asked them, did they change their patterns? But not that many people changed. It was these 5% that were changing around that caused us a lot of problems, but not as many as you would think, given just the ordinary migration in a city because of rents and stuff. So, now here's another before-after type of comparison, actually looking at the rates for TB. When you look at it, the rates did go down, 15 to 20%. For the combined outcome of TB, earliest to TB or death, there's also a slightly larger effect here. But now again, this is such a crude analysis that you don't believe it, just because there's so much going on. And in the Cox models, for our main outcome, well, all our Brazilian colleagues were unhappy to see we didn't get a very statistically significant result here. But that was our primary outcome. Now the combined outcome, though, had a lot more events and a slightly smaller hazard ratio here, which was quite significant. And you know, we didn't have as many events as we were hoping for here. We certainly, TB or death, we had a ton of them. Also in our stayers analysis now, these are people who were coming in once a year and getting CD4s, so they had some constant clinic contact. They didn't just go away for years and never come back. We had a much bigger effect here. This is 40% effects that we were looking for to start with. And these are really, they really are different people, and then they are being in contact, and so you expect them to benefit from the intervention. However, we're investigating some other problems there with regard to missingness of CD4, because we're worried about we have this problem where people are coming, you know, they're in this study, their HIV disease is progressing, they're making somewhat regular contacts, but then all of a sudden they get worse, and most of the time later is during intervention phase when all of a sudden they decline. And the people that aren't having the CD4s seem to be declining faster. Anyway, we're starting to investigate some of these covariates, and with the secular trends we saw, you know, there could be all sorts of problems there. But the basic results, it makes sense to us anyway. Just some of the covariate ones didn't. I'm just going to conclude here, just in time for Jeremy here. Here we have, with the design, okay, we have some things we got to worry about, the loss of power and how to deal with the randomization, and then how to deal with the lag when there's implementation of the intervention or of the uptake of the intervention. Happily, the uptake of intervention is not related in this design to the intervention itself, which is not the case in another Stepped-Wedge study we have going on. I don't know, I'm not the main statistician on that. We haven't figured out how to do it though. But anyway, you don't want either vertical or horizontal, but these diagonal analyses that account for that lag. And you got to do a lot of cross-checks. We've been doing a lot of them and thinking carefully about who's being intervened and when and so forth. But still, there may be some secular trends and aging of cohort problems that people have referred to in some of these other articles when you have a cohort. Luckily, we had a dynamic cohort, so those are somewhat mitigated by the fact there's keeping refreshment of the sample. But you know, these things all make you nervous enough that my suggestion is use a parallel design if you can. Okay? I mean, we really didn't have much choice. We had political and logistical reasons to do it. As I said before, the ethics don't really come into it because actually it just makes for a longer study. But you know, it's fun to do these designs, but it's more of a pain. It does keep statisticians employed, though, so I guess we can say there's some positive things there. So I'll stop there.
Thank you very much. I think we've got time for a couple of questions before
Yeah, I went on
hand over to Simon.
quite a bit longer than I should have there.
No, in a parallel group design, if you retained members of the intervention arm who didn't get their intervention until a certain point, if you retained them on the control arm until then you would suffer a potentially rather large selection bias. And we would usually do intention to treat analysis, which would say we will allocate them we'll put them on the intervention arm.
Yeah.
Surely exactly the same argument applies here. I would have expected you to be doing intention to treat. So putting them on the intervention arm the moment their cluster was allocated. And I would have thought you risk a bias because people who don't go to clinic are preferentially ending up on the control arm. And, well, I mean, I can only speculate how people who don't go to clinic differ from those who do, but I bet they do differ.
Yes, and the main thing is that here, I mean, we were able to bracket a bit by having these stairs analyses too, which is that we wanted to get something that would look like a parameter that corresponds to what happens in the long term. And in the long term, you don't have this artificial thing coming in of the intervention, in that the intervention is always there. And so to make that look like the population, that's why we said, well, we'll wait till the person shows up in intervention to call them intervention. And now, if they've been in the study, of course, they're still contributing time. If they're brand new, they don't even contribute to the control there. But the idea is to sort of mimic that long-term parameter. What would happen if this were always around? You didn't have that artificial, point of putting the intervention in there. And it just, we probably will end up, and actually I think it's in our analysis plan, do the pure intention to treat thing as well. But it just didn't seem a parameter of interest. Just like in vaccine studies, the pure intention to treat is what you were randomized to, but the parameter everyone wants to know is what vaccine you actually got. Okay, and there's always 2 or 3 out of 1,000 mix-ups, and so that's the parameter we really go with, is a modified intent to treat. Or, did they get their first vaccine, and there might have been a period of time beforehand to the time that they show up again to get fully consented and vaccinated, and they might not have shown up. Well, we don't even count those in the vaccine studies.
So that's more
but-
plausibly balanced across randomized groups, I think, in
Yeah,
vaccine
yeah,
studies.
yeah. Then you can have a bit of a problem here if you just wait that extra few months. Yeah, there is a problem with this cohort thing, just trying to figure out what to do.
Yeah, the same, similar, but it's a slightly different question about when you count someone as being in the treated numbers. Because it's on to do with the clinic visit. So I think that question was about, well, if they're not coming very often anyway, that's a different part of the population. But also within the population, the fact that someone shows up at the clinic could be informative about what's going to happen to them next.
Yeah, and it clearly is, because we had such different results when we did the stayers analysis, and threw out people that didn't come in at least once a year. Then it was made very obvious that there are different types of people, and so if you can get someone to show up once a year, this is the effect you'll have. If you go
But I was thinking it's not so much one of the different types of people. It's just that for a regular person, if they're about to go down with TB, then maybe there's something that happens that a little earlier
makes
than
them
that
come in.
has them come into the clinic, and then they get put in the other group. So that's
that can happen too. Yeah, the only thing we could deal with were the absolute ones who had no contact before, and then were the prevalent TBs. But yeah, there could be that type of thing happening even to those who've been in there all the time. You're exactly right.
Does the treatment work fairly instantaneously when you start taking sizes, does that mean you have a much lower risk of getting TB, or does it take a while to build it?
Well, it's hard to tell because no one ever has enough data on this, but it seems to be within about a month anyway to build up and so forth. Yeah, it's pretty. Yeah, it's not like heart, which takes maybe 3 to 6 months for your viral loads to be suppressed. It's acting much quicker than that, which is luckily enough.
Well, you hear so few talks with any discussion about randomization. Rosemary's talk.
Yeah, well,
I mean, you did so much work with that, well, you call it a constrained reference set, I guess. I would call it a conditional reference set. Calculating a conditional reference set. Even though you're interested in individual, I'd be kind of interested in doing a randomization test. Conditional for comparing.
And that would be another good check, because you can do a randomization test based on just those possible randomizations and get a true, purely accurate p-value out of it. But it would be a huge pain, and we're doing thousands of analyses with it, and basically you want to be able to just use our regular analyses to do it. And also that's a whole other type of statistical inference too, where you believe the randomization is inducing the random error, not the novel. But, so there's all sorts of different things, but it would be a good thing to do
Well, you would have to figure out how to generate from the
from the constraint.
conditional.
From the constrained set. And you could do that and permute around and stuff.
That would overcome all those.
The validity check, you wouldn't have to do that. You wouldn't have to do that validity check.
Oh,
But I wouldn't, but I'm telling you, I'm sure I'm not off the alpha more than 1%. I'll bet any amount of money on that.
I just wanted to,
Yeah.
you thought you were waiting for me to criticise you. I was just dead impressed that you had done that validity check.
Oh,
Because
yeah.
I've seen lots of cases where if you
Yeah.
balance on some
Yeah.
covariates,
Yeah,
the result can be that you're actually completely confounded with interaction
Yeah.
between covariates.
yeah.
And
No, I saw a
when you did
paper
that-
balancing on propensity scores a year ago in biometrics. There's no discussion of that at all.
Absolutely. So
And
please keep
I would
doing
have
that.
been lost without you and R.A. Fisher there, Sir Ronald.
It's R.A. Bailey, not R.A. Fisher.
Yeah, that's it. I would have been lost without the 2 RAs, though. Without the 2 RAs, I would have been lost, for sure. But yeah, randomization, you're right, a randomization test, you don't have to worry about it, but then,
That's probably a good time to move
Okay.
on, so thank you very much for
Okay,
that.
sorry to
That was
take so
really
long there.
interesting. So our third speaker is Simon.